Good afternoon. Welcome. It's July 22nd, Thursday, around 1 p.m. in the afternoon, West Coast time, and it's THCB Gang. I am your host, Matthew Holt, founder, publisher, editor, and occasional writer on THCB. And we have a fab, small but very mighty guest lineup today. I have with me a real broadcast media professional, Casey Quinlan from Mighty Casey Media. Lovely to see you, Casey. Ian Morrison, futurist, and Michael Millenson, wit, curmudgeon, and healthcare quality expert. And this is THCB Gang, which I screwed up the start of the first time round. So if you're hearing this version, that means you didn't see it live, you got the cut. All right, so let's kick off, guys. How have we been this week? So first off, Casey, can we get a real quick update on your how you're doing?
Well, I'm doing much better than I was when no one saw me for a few months. I am doing easily as well, possibly a bit better than I was a couple of weeks ago, the last time I appeared in these precincts. So bottom line, I'll just kind of try to keep that trend going because that's, important to me. But, we'll just, sort of keep going in this positive direction and hope for no change. That's where I'm at right now.
Our fingers are crossed, but I saw you've been walking at least to your car and driving a bit and getting out, which is
well, yeah. I mean, I would lose a race with a tortoise on the Galapagos Island right now. But that's
That's good. Well, better than as we all say, better than the alternative. All right. Well, let's kick off with a quick roundup of what we've been looking at this week. Let me start with you, Michael.
Well, first of all, it's great to see Mighty Casey on her way back to being just as mighty as ever. So we can all hope for that, Casey. That's good to hear that there's good news, even if slowly improving good news. But at least Casey has a trend, whereas our healthcare system is, as usual, confused as to what's going on. So we have kind of let's get back to healthcare policy as usual, in which case let's talk about the evil drug companies with opioids and with high-priced drugs that don't work through the FDA. And the hospitals are billing people that they shouldn't be billing, and we're charging people for COVID tests and all the other profit maximizing tricks that make our healthcare system so beloved by patients and healthcare wonks alike. At the same time, we have public health initiatives that relate to COVID and to the Delta variant and to all the other ways we need to deal with COVID. And then beyond all that is sort of the lurking panic that we're going to hit a second wave. Our attention span for doing anything about it has been exhausted because we're Americans, and really a pandemic that lasted more than a few weeks was really too much for us. Having the patience of a valley girl in a waiting in line for a movie. You remember those. And so I think we've got a lot of potential for more and more confusion. And it'll be interesting as Congress finishes what legislation we get in a conventional sense as we race the clock against, oh my God, we're going to have to pay attention to COVID again. So it's unfortunately interesting times is what I would say.
Well, that's a good backdrop. Ian, what have you been looking at?
Well, I just to pick up on a couple of those threads, and it's great to see Casey. I was sort of bemused this week, and maybe you can help me all explain it, of Hannity turning into a modern version of Fauci. He's suddenly in favor of vaccines and urging people to get them, as are a number of prominent Republicans.
But here's the big question: are any of them willing to publicly go toe-to-toe with Rand Paul?
Yeah, there you go.
By the way, I wonder about Rand Paul, apart from everything else, is a physician. Have you seen the AMA issue any sort of statement about a physician should not be doing this? Have you seen
I think he's not. I think he's an optometrist, right?
No,
he's a physician.
Ophthalmologist.
He's an ophthalmologist.
But he's never been board certified in anything.
But
maybe
he is
you
a
can see
he is
why.
a physician, first do no harm and all the rest of that. And yet you see no pushback. There is a physicians caucus on Capitol Hill that is almost exclusively Republicans. And so it shows the instead of the Hippocratic oath, the hypocritical oath that medical organizations take: first do no harm to our politics. And it's even in the face of a pandemic.
Well, the cynical amongst us know that when was it Newsmax and One American Network started apologizing to the voting machine manufacturers because they're about to get lawsuit that why was this week that Fox News all started saying, well, perhaps you should get vaccinated, having banged. I don't know if Tucker Carlson joined in, but the rest of them banged the drum on this, and wonder if something happened in the Murdochs. In the Murdoch world that made that come up. I don't know if you have any opinions on that one, Ian.
Well, no, I mean, the one speculation was the market went down on Monday, and it may have been Trump who said, "Oh my God, we better fix this." So who knows? But I thought the sea change was significant, and it's in the face of, as Michael pointed out, the Delta variant, which is just going. I mean, I just looked at the cases. We're up 171%, 14-day trend on cases, and 40% on deaths. It's going up in the UK big time, and
yeah, it's going up. It's on. There was a headline in the Virginia Mercury in Richmond, Virginia, where I live, that our trend, which had been down for here in Virginia, now like going back up.
In the face of this resurgence, I would expect Delta Airlines to announce that it's only serving Corona beer.
Yeah. But that's such terrible beer. Okay, now the Corona people are going to come after me. But
there was a massive. You remember at the start of this, there was a massive rise in searches for Corona, and no one could quite figure out what was going on.
Right.
All right. Okay. So we had the whole world from Michael. We had Fox News and vaccines as their kickoff. Casey, what have you been looking at this week? What's your nugget?
Well, I mean, I'm kind of doing the backstroke across the diversity and inclusion discussions that I'm seeing. Being a female human, I've been aware that lots of people get left behind because I'm in the group female people, particularly of a certain age. We won't say what that is, but it's certainly older. I'm over 30. We'll just put it that way. Well over 30. But I see so much performative nonsense going on out there. And I once again take great solace in reading and listening to, physicians of color, policy wonks of color, just anybody with a brain of color. Okay, what's your perspective on this? I want to hear what you have to say. And, I do when she's actually working for Yankee Dollar, world, I work with a major publisher producing podcasts for medical societies. And one of them is the American College of Emergency Physicians. And Cedric Dark is taking over as the editor. He's an emergency physician at Baylor, is taking over as the editor of the magazine that's, putting out this podcast that I'm putting together. So I got excited because someone I follow on Twitter, who's like a big name to me, suddenly there he was on my Zoom screen. And anyway, so I've been listening to a lot of voices that are not the usual suspects, or at least not the usual suspects in terms of the ones that are on the Sabbath gas bags, or anybody who has a risk of becoming a Sabbath gas bag. And if you don't know what that is, just go Google it. Calvin Trillin will come up and it'll be funny. But anyway, I'm tired of listening to people talk about who've been been in their position for 10, 15, 20 years and who are still talking like they're making change when I know they're not. And that's why I'm frustrated. Probably 24 hours a day, 7 days a week, 365 days a year, because nothing changes. But, like Max Planck said, the field advances one funeral at a time. That's not exactly what he said, but that's my version of it.
Hey, Casey, apart from the fact that I feel excluded as a Jewish person by the Sabbath gas bag analogy,
Don't you have Shabbos? It could be on it could be on a Friday night.
Apart from your exclusionary language, which I will overlook at the moment, Calvin Trillin, who I believe might be of a different ethnicity, perhaps they changed the name on the way over from the Mayflower. But what I would like to comment on things not changing is I came across an article I wrote when I was a reporter for the Chicago Tribune in 1983. Talking about a study from the American College of Healthcare Executives about minorities being excluded and not getting a fair shake and all the things happening to Blacks. 1983. And of course, all the organizations saying we're going to do something about it. It would be nice if, apart from sincere statements, some of the organizations really came to grips with how long they've been promising, not just the issue, but how long they've been promising to do something about it, and sort of ask, well, why haven't we? And because I think that would be really productive, because the intentions are good, the execution is weak, and like so much in healthcare, being patient-centered, being safe, being consistent with guidelines, all those kinds of things. The execution has been weak despite good intention. And I think a real soul searching would include that.
Yeah. Sorry.
Go on, Ian, quickly, and then let's come back to this in a second. I want to give you my two.
Well, no, I was just going to say it's like so many of these trends or supposed trends is that the PowerPoint is ahead of the reality, right? And we sort of bemoan it, but we've been bemoaning them all for 45 years. To Michael's point.
Well, let's take on a couple of things we've been bemoaning. So I have two nuggets and news for you. First one is on the COVID story. New York City Police Department, apparently vaccination rate amongst New York City Police Department employees, including obviously the policemen, 44%.
Oh my God.
I've just looked up New York State as a whole. 67% of the 18 plus population is fully vaccinated. So they're running, basically 20 points behind for public safety workers. And I hate to say it, but you saw some of the activity of the New York City Police Department against the Black Lives Matter protesters last year.
If you look at the Fraternal Order of Police,
it tells you a lot, right?
I lived in New York for almost 30 years, and I'm only too familiar with that particular culture.
Well, I think that to me was pretty shocking, and you put that with Macron in France's basic declaration that anybody who's going to do anything off the public purse, including employees, but then basically people receiving services, are going to have to get vaccinated or else be basically kicked off the thing. They're getting. You can see people starting to get serious, and I don't know how that happens for police, but I know that some hospitals are starting to get serious. But that was a shocking number to me, and showed me that the politics of who's in the police department is probably very opposed to the politics of the people they're policing, given the overall strategy, overall demographics of New York and New York City.
Matthew, just a coda to that. You mentioned hospitals. I mean, yesterday I think it was the AHA firmly declared a policy of advocating for mandatory vaccination for employees. So I think, and there's so many systems who have flipped over. I've been drumming this in the institutions I've been exposed to, but I think the weight is now on the side of mandates for vaccination.
I mean, it's going to come. And you see, there's a court case between Carnival Cruises in Florida about whether they have the right to take on passengers in Florida and demand they have vaccines. And I'm seeing a whole bunch on the tech side of people with different types of passports and all that kind of stuff.
Yeah.
My second one, we got to mention it. New York Times reported on the JAMA study from the cross Harvard Stanford team on medical debt. Yeah. $140 billion in medical debt is out there, presumably in collections.
And most of it is people who have insurance of some form.
Well, what's worse is
more than half, majority.
17% of Americans, so 1 in 6 Americans, has got medical debt in collections. Not like they owe some money in the $10 and they haven't paid their copay, but they're actually being collected on, despite the fact all these hospitals who allegedly stopped the collections process and stopped suing people, all that kind of stuff. And of course, as you would expect, it's worse, as they said, in the lowest decile income group, i.e. poor people and poor people in the South where they haven't expanded Medicaid. are the most likely to be in that group. And that just, as a coda to that, I got 3 emails from techie PR people at techie companies saying, "Oh, can we comment? Can we have our CEO comment on that because we've got a solution for this?" The solution that in all cases seems to be lending people money in order to get them out of debt,
Right.
basically. So we still have this issue of charging poor people.
No. Yeah.
Yeah,
No.
or tell you
Really?
in advance with advanced tech that you're going to be impoverished for life. We know but do it with very good graphics.
But we know in some of the worst lawsuits, right? I remember there was one in a hospital in Memphis which got got exposed by ProPublica and some local journalists there. That they were literally, one of the people being sued was an employee of the hospital who was a janitor or something, making
the same thing happened at the University of Virginia.
Exactly. University of Virginia, as Jeff said, at least they put a new management team in, which went and actually pulled all the liens and did the whole work of stopping people. But they were suing their own employee and garnishing their wages for $3 an hour. I mean, incredible stuff. And you can't have, basically you're saying to extremely poor people who can't raise $500 for emergency bill, we want $20,000 off you or $10,000 off you. It's never going to work. And yet nobody seems prepared to come up with a solution to this problem.
Well, I mean, the surprise bill thing.
It's pretty obvious to me what the solution is, but
okay, that solution, it seems the having it all free at the point of service seems to be unobtainable. Ian, sorry, you're saying?
No. I think it ties to the surprise billing story as well. Which where a lot of that stuff is really it's not the only source of debts, but it is a primary source. And some systems have done a better job than others. I mean, Memorial in Long Beach, I think, has gone to the trouble of insisting all their docs are in contract, so you don't get, quite the same effect. But go ahead.
I just read Marshall Allen's book about, don't pay the first bill. And he did a good job from ProPublica based, on some of their work and advice. But I think what Matthew said is important is that, yes, in theory, there are ways you can push back and all the rest of that. But if you were poor and, don't feel very comfortable over the phone with your English proficiency or a lot of other things, it is very difficult to argue and to debate and to go against a large institution. You just feel powerless, and it's tough. I mean, it's tough if you're middle class and articulate. And I think that expecting people to bargain is absurd. I mean, I've occasionally done it, but I know what I'm doing, and I'm doing it on certain kinds of things. If I was getting a heart bypass operation or being treated for my stroke at the ER, I really don't think I would be much of a bargainer either before or after, right? And so it basically comes down to the consolidation, allowing people to control things. And as we've gotten more and more private equity firms taken over, right? It's a bad situation. Maybe we need some congressman's kid to end up with a surprise medical bill, and that might get some attention.
Yeah. All right. Well, no, I mean, we've beaten that one to death over, on this show, but over previous shows. But I think it's just got to remind us that despite the fact we went through the pandemic, and despite the fact there was a lot of cash support out of the different, recovery acts and the previous, the CARES Act, what have you, to individuals, there was also a ton, and I'm going to say this again, it will piss Ian off, but there's also a ton of money in the CARES Act sent directly to institutions,
right?
Most of whom put it straight in the stock market and made money off it.
So Matthew, what I think we need is the Nonprofit Debt Consolidation Act, where you take the money you owe to your nonprofit college and the money you owe to your nonprofit hospital, and maybe the money you owe to and you combine it into one big package where you owe all the money that you'll ever earn in your life to nonprofits.
And then you solve that.
Write it all off right then.
Right. You
solve that by confiscating the reserves played on which the hedge fund reserves playing on the stock market. Those big non-profit. I don't know if the equation quite adds up, but my guess is there's like 100 to 150 billion in those reserves on the.
Maybe
if you add the universities, if you put in the Harvard endowment and the Stanford endowment,
that's right.
So you've got plenty of money to put that all away.
So
Well,
I
you
think
package it.
we square it all off.
You package it like those mortgage packages that gave us the 2008 recession. You package all the debt that we owe to our colleges and our hospitals, and you sell them off as debt packages on Wall Street. I mean, the private market can take care of this, right away.
Selena Gomez can explain it to you in the movie about how it all goes wrong. Or whoever the Selena Gomez of 2027 will be. For those of you who saw the Big Short.
I'm just trying to be helpful.
No, it's a great scene where she's explaining on the craps table how glad I get up and get you from work. Wonderful. And then Margot Robbie in the bath explaining how bad debt was. It's marvelous stuff. All right. Okay. Can we go back to the? Can we go back and raise the thing that, because I kind of interrupted because I wanted to get that in, but the stuff that Casey raised, the issue that Casey raised about about looking for sort of lip service to diversity. Ian said, we've been talking about the same stuff for 45 years.
It's not just like diversity, it's really equity. And I mean, when somebody hits the door of a healthcare provider, whether it's a hospital or a clinic or whatever it is, when someone hits the door of a healthcare provider, I would like them to feel as though there was at least a chance that they could see someone like themselves on the other side of the stethoscope. And, that would be nirvana to me. But, you're talking to somebody who's very studiously sought care, mostly from female physicians since college. Yeah, I had some bad experiences with dudes. So, dude doctors. And to me, it makes perfect sense that people who are not the usual white male construct might be a little suspicious of a power structure that basically only has white male avatars. But anyway, that could just be me.
Well, I don't think so, because there was a piece. I need to go Google this while we're talking, but there was a piece out from Robert Johnson Foundation recently, last week, 10 days, which said that black patients and white patients treated in the same hospital ended up with different levels of care. Because there was always, and Jeff Coulter.
It was on safety. It was on patient safety for black and white in the same hospital. It was fascinating. I've got a piece I'm working on some of the equity issues, and I was a little bit disturbed by some of the cliches I heard, and so I went and I spoke to two black female clinicians I know who are really smart and really into quality, and I said, okay, this kind of cliche. Equity is quality and all the rest. It just sort of seems to me an oversimplification. What do you think? And they were talking about it some, but to boil it down, and this goes, I think, Casey, what you were saying, if in fact you end up treating implicit bias seriously, right? Because it's not a question of you walk in to see a male physician, he looks at you and says, I don't like women. It's not that simple, right? So if you treat implicit bias seriously, you actually end up helping pretty much every patient, because the fact is that there's all sorts of issues that, you're too young, you're too old, you're a different color or ethnicity or gender or sexual preference. There's lots of things that go into it. And if you attack implicit bias explicitly, you actually end up helping white people as well, as it were, right? Unless you're, an average white male with only average needs, right? Everybody has some particularity. And I think some of the people who are down on equity for whatever ideological reasons that might be, are not really hearing the fact that, yes, it's you too, right? Yeah. And so that to me, these women were both frontline clinicians. So to Ian's previous point, this wasn't the PowerPoint, this was the real thing, right? And I think that if we start to listen to some of the frontline clinicians who are really doing something on this, we will be better off than some of the grand proclamations by people in conferences.
Yeah, I agree about the frontline point, but it also, I think on the other side, it starts at the board level of organizations. Yeah, well, right. I was on the board of the California Healthcare Foundation for a decade, and we were extremely diverse in both gender and race. And, you know, I was one of the token white guys, but
But you were a distinct minority, don't forget, let's be clear.
I believe you were representing immigrants.
The poor Scottish immigrant, right.
I was
the Scottish immigrant population.
Yeah, exactly.
You had to leave his sheep outside the boardroom.
But my point is that you know, you have to be purposeful at the board level to say, we're going to look for candidates who are, you know, not white males. I mean, I'm sorry, you just got to make it the case that why wouldn't we find qualified candidates of color? And the same is true all the way through the system.
So I have a point of this. We had a show a few weeks back. I think Casey, you were on this with Michael, you were on it with Christina Liu, who is the THCB editor. She does the work around here, and Christina's just applied for medical school. And there was, you know, the effort and activity. You know, look, she's a smart kid, Northwestern graduate, blah blah blah. But the effort and cost of just applying to medical school, just the applications, and we might not get in, right? More people applied to get in, was really, really significant. And I think, you know, that, and we know the type of effort it takes to go through medical school, go through residency, you know, and other roles in the health professions, the sort of the effort involved in then continuing up your certification as you go through the process. But I mean, you know, if you think about that and then go back into and I had a conversation at dinner last night with some friends from the UK who came over, and I was talking to a high school senior, what are you? Post high school senior, she's just graduated, about the level of effort, you know, it was taking to get into, certainly to get into the sort of the well-known colleges, just because of the number of places in those colleges and some of those medical schools haven't expanded at the rate in which the population expanded. And by the way, you know, to kind of liven up Casey and Michael, you know, for back in the day, Harvard, Yale, Stanford probably weren't letting females or Jews or black people in, right? But now they are, and there's still, you know, the same number of undergraduate places because they're elite colleges. Now maybe it'll go online or change it somewhere, but we're talking about a system in which, from the earliest times, you know, there's great inequity, you know, right, birth going all the way through kindergarten, those early years, all the way through school systems, and then, you know, the pressure to get into these institutions is tougher and tougher. It's not surprising that we end up with, you know, professions like physicians, which are high, you know, high status, high income professions, you know, being kind of semi-captured. I mean, I know there are more female physicians in medical school now than there used to be, but again, I'm with Ian. You've got to say the institutions, the organizations have got to say we have to make a big effort, and it has to be reflected in wider society, because you can't expect, you know, people who are smart enough and have got the money to not to try to get in, you know, to medical school or wherever else. So it's part of a much bigger social issue. But I'm with you, Ian. You've got to have the board actually do this. And the guy I've seen who's been most aggressive about this has been Sachin Jain, who's now was at CareMore, now at Scan Health Plan, who's aggressively said that, you know, we are going to change the metrics. We judge everyone on the board and senior management to hit these metrics about service and inclusion and stuff, because if you don't really put it in how people get paid, they're not going to worry about it.
Right.
Yeah.
I think that's right.
Well, and that goes obviously to some of the other things with quality, safety, and the rest. But it's interesting on the medical schools. I remember years ago, you'd hear the AMA talking about the dangers of physician surplus, right? And it always struck me as bizarre, like a danger to who exactly? And yet there's no pushback from policy people. Oh, it will be dangerous. We'll have too many doctors, and as a result, what exactly? And so you have that constraint of supply, at least as far as medical schools go, because you know, and of course we don't want to let nurse practitioners or anybody else practice too high either. We want to constrain the number of doctors, constrain the competition, and thank God it's all for the benefit of patients.
Well, there is. Go on, Casey.
I just did some well, it's not quite back of the napkin. It's, you know, on my reporter's notebook, but I just did a quick calculation for one school. In other words, applying to one medical school, following the rubric of, you know, you got to take the MCAT, and, you know, that's the medical college aptitude test, I believe. But anyway, you got to take the MCAT, and this doesn't include MCAT prep courses. Between the MCAT, the application, the secondary application, Go Google that. You can figure that out. Per interview cost, that alone adds up to somewhere around $900. And then you will have to stroke a check of anywhere from like $1,000 to $3,000 to the school that accepts you to reserve your spot. You have to be ready to do that as well if you get accepted, and that's for one school.
Yeah, and I think Christina applied to 10.
Now imagine some kid who's brilliant and who lives in a neighborhood where they shot the wire in Baltimore. You know, it's like, come on, No,
it's something clearly has to be. I mean, and there are things right, but even just the time involved, right? The effort, the fact that they don't have a common.
Oh yeah, that doesn't format. Take any. If you take
common
any
format for it,
into consideration.
It's crazy, right? I had something genius to say about what Michael said, and I forgot. But
if I could just add a footnote, and there's one of the things that's interesting is that applicants to medical school went up about 20% this year, largely because of the halo effect, I think, of heroism and COVID. But I was talking to Bob Walker about it, and he said it's also because the way in which this year's applicants were processed was largely over Zoom. So they didn't have the travel expenses of going to places. So while it still is exactly the math that Casey points out, you're saving the bus fare basically.
Yeah, that was, I calculated in as like, $400 to $500 per interview.
Yeah.
If you had to travel and,
Yeah, so it probably lowers the cost and also lowers the time, right? I mean, I remember Christina saying she applied to 10 or 12 medical schools, and some people in her class were applying to many more,
And Matthew, if I may, it just ties into a question I keep having for particularly the Health 2.0 experts is, where are the doctors going to come from for all of this? It's all very well if you are a startup and you've got a few moonlighting doctors from the local hospital who are, if you're going to scale up to be a $2 billion enterprise, you got to have a lot of doctors. And if you look at, I did some work for one of my clients who's a malpractice company about future trends. I mean, the AMA tracks this stuff. There's still this relentless drift toward large group practice owned by health systems. You survey, resident physicians graduating, 40% of them want an employed job with a large health system. Walker tweeted last week that he's losing residents not to other academic medical centers, but to these digital startups. And you've got all these private equity guys running around trying to buy practices. So one of my questions is, how's this all going to end? And are we going to bid up the price of these dogs?
So one is we're bidding up the price of doctors, no question already for that. And we are in a moment. This is kind of like we're all old enough on this episode of the gang to remember 1998, 1999, 2000, when first year lawyers at law school were all being paid like $190,000 a year to stop them going to work for .coms. That didn't last for a while because it all fell apart. There's a little bit of that going on. I have a lot of the sort of digital health, Health 2.0 type companies in my orbit looking for, they can usually get away with a part-time medical officer, but by the time they get to the point of needing somebody full-time, there's a little bidding war for that. And there's a lot of interest in doctors, by the way, a lot of doctors who want to give up day-to-day medical practice and go do that. And perhaps they weren't best suited to be a medical practitioner.
So there's another issue there, though, which, I started to talk about this a number of years ago, but of course, again, like a doctor surplus, it doesn't take anything. You've never seen anything in the medical journals as, okay, medical school is to some extent subsidized by society, no matter the cost is, because of the whole thing, we're going to produce doctors. You went through with a subsidy and now you become an investment banker or you go to work for a .com, you really don't practice. Why? Again, if we believe in capitalism and, then you pay it back, right? Opportunity and cost. And so why don't we have somebody who was trained with a system that never conceived of a Health 2.0 company, right? Or a doctor who was an investment banker. If you're not going to treat people, pay back the money. Right?
Well, you can argue about that. That's clearly true for residency, right? Which has a massive subsidy. For
residency, right.
And you can argue medical school back and forth about how much subsidy there is versus that. But I mean, but this is an uncomfortable discussion probably for me and Ian, because we went to school in the country where we didn't pay tax
They
We're
paid
now paying
us.
tax in a country where we didn't go to school. Although, and if we're clever, we move back to the UK for the NHS.
With all due respect to your both distinguished gentlemen, there is a difference between being a physician and curing people and being a health policy expert and talking about physicians who are curing people.
Yeah, because we all do a lot of talking about this.
And the second thing, by the way, which bothers me, and again, I haven't seen anybody write about it, is, you know, there's a saying that where you sit is where you stand, right? That your job affects what you're saying. And one of the things that is bothersome is, as much as you and I know physicians who we like, who we trust, who are wonderful people, who spend their spare time, you know, helping orphans and little puppies, when they get a job in a for-profit company, especially one that's about to go public or has gone public, they end up having to make decisions that honor what their employer wants. And so you start to wonder over time, what happens to medical ethics as more and more doctors are employed, not merely by benevolent private equity companies as they treat patients, but by tech companies driven by certain imperatives. And so we know that they need them, and it's great, but where you sit is where you stand. And just like the physicians we know who are great people and work for pharma companies, honestly believe in what is essentially pharma company propaganda, that, you know, if you take $1 off of the price of our drug, innovation will drop by $2, right? One wonders whether or not these good people will over time essentially be captured by the propaganda of the tech industry. And
that to me, that horse left the barn so many decades, so many centuries ago that it's irrelevant. I mean, because you're either working for a drug company, you're working for a hospital system, you're working for a health plan, or you're working for yourself but being paid fee for service. Okay. I think that I would say there's a lot of guilt. You know, if you look at that, that's a good point. I would say one thing I did want to bring up that we haven't mentioned, right, which is talk about doctor surplus and the rest of it. I was discussing with, I went to lunch with a brilliant young doctor who trained in the UK and is now running a health tech startup here. By the way, her health tech startup is called Incredible Health, and it's basically a new style tech enabled sort of LinkedIn plus recruiting service for nurses and hospitals, right? So that's what it does. But anyway, so that's what she's doing. She grew up in a family of surgeons. She herself is anyway. She said, well, you know, we were discussing training periods in the UK versus the US and how quickly you get out of the system in the UK, because you go immediately to medical school at 18. You're in the system. You're through in 6 years. You're in the system in your early 20s. Whereas here you have to start a medical school in your early 20s, go to fellowship. She said, yeah, but to get to the end, to be an attending takes a lot longer in the UK. They call them consultants. My dad was one, right? Which is the specialist at a hospital who runs the show and is allowed to, and it's the attending and is allowed to, you know, takes many more years to get there, whereas here you can get there kind of quicker. I said, yes, that's because in the UK, they limit the number of specialty places, whereas here we don't. So when if you're going to talk about physician surplus and all the rest of it, and, you know, Wemberg and all the folks at Dom have banged this drum for 30 years, if you allow 75% of the doctors to be specialists and basically create their own demand, as Fuchs and Uwe Reinhardt taught us for years, you know, that's very different to talk about what you know, how many doctors do you need. I've always gone back to, and I'm going to bang the drum for this again, that if you look at some of the concierge primary care practices, you would only need, if you got to the average of, God, I forget, I've done the data on the back of the napkin. If you got to the average of 500, yes, if you got to the average of 500 patients per doctor, per primary care doc, you could give everybody concierge medical care for less we spend on healthcare all over for the, you know, and you would need something in the order of 500,000 to 600,000 primary care docs, and we only have a couple of 100,000 because although we have 800,000 doctors, most of them are highly paid specialists. Now,
right, because primary care docs need primary care.
If you did that, believe it or not, if you did that and you paid the average concierge fee, which is about $1,500 a year, each one of those doctors could make $750 a year. Well, their practice could make $750 a year and have a lot. There are ways you get to them making a lot more money now than primary care doctors make now. But of course, you'd have to upend the system, and the result would end up being what every one of the digital health tech-enabled service companies, whether they be One Medical, which is fee for service, or IORA, which is predominantly Medicare Advantage, or whomever else, they'll say, if you put patients into our system, we will lower hospital costs, we will lower specialty costs, and so therefore it's worth saving us more. This has to be proved at scale. We don't see the system price going down, but it all kind of plays in. We could rearrange the system dramatically and make it so that worked, and so that everybody could be, as Ian says, part of Teladoc or One Medicine or whatever. But we would really require, again, it's going back to changing medical school, changing residency places, and changing the way we pay specialists versus generalists.
And if you really want to get suicidal, follow those recommendations and that thinking through the lens of how we observed healthcare in this country playing out during a pandemic, which is still going on, with all kinds of, well, I don't believe in that, believing in the whether or not there's a virus. I'm sorry, but you've lost me. And then, because I'm officially an old, I'm old enough to remember dimly what polio summers were like before Jonas Salk came up with the Salk vaccine. So my mother, being science girl, of course, had me, I was like first in line, I think, in our town to get that. And, I don't understand how we have gone from a country that did seem to care about the collective good, or at least in theory, but now have become like we're just mean. We like to be mean, and we construct systems that are mean AF, unless you have a lot of money. If you have money, then you're fine. And it's just been all of this, sort of the dead fish at the bottom of the lake. The tide went out during the pandemic, and we can now smell all the dead fish, but are we doing anything about it? Oh, not yet.
I mean, we've had this discussion many times on this show with various members of the gang, which is that, and way back in last June, July, hospitals were not doing elective surgery, not making any money. Primary care offices were shut, didn't have a way of billing fee for service. And we said, isn't this the opportunity to talk about the system sensibly and say, can we put it on some kind of subscription capitation basis? I mean, my crackpot theory about giving everyone a concierge medicine doc and $1,500 for primary care is not a terrible idea, but that wasn't advanced. But nothing's changed, right? We doled out money from the CARES Act to the hospitals who didn't need it, and we have not seen a substantial change. I mean, I hear a lot of conversation about value-based care and changing and what have you, but in reality, it's still small.
So Matthew, let me ask you a question.
Hang on, Michael, then Ian, then Casey. I've made it one.
Real quick question. So I was intrigued by what you said, and I would agree with you that turn the swords into plowshares. Let's turn ophthalmologists and plastic surgeons into primary care doctors, which is just about as practical as waiting for the Messiah to turn swords into plowshares. But my question for you is, if you took the idea that you just outlined with your back of a napkin or whatever calculations, and tomorrow the governor of California came to you and said, I always watched THCB Gang, and boy, that was a great idea. Would you be able to do what you propose within one state? Presuming that you went and you jawboned the private insurers to go along with you. If you wanted to change payment and education, could you say to all the organizations training doctors in the state of California, and knowing that they'd be happy, and if you've got all the insurers to go along, could you do it?
I mean, the reason you could, this is fantasy land, right? It's never going to happen. But the reason you could is because, don't forget, most doctors get trained as generalists first before they
right.
So theoretically, you could turn it. The ophthalmologist and the dermatologist who haven't seen a regular mixed panel patients for a long time, but theoretically they have that basic level, right? And you have a lot of internal medicine docs who then gone off and become subspecialists and pulmonologists. So you could probably route people back and say, we're going to pay you this big whack because we're now paying primary care at 50% of the dollar instead of 20% or whatever it is. So the other reason you could is because now you've got now you're going to accuse you of really being in cloud cuckoo fantasy land. You've got all this new tech, AI support, bots, whatever, which could do a lot of that work. So, whether or not you believe it, in recent weeks, we've seen Babylon Health, right, start buying medical groups in recent months,
Right,
groups in California, with the idea of putting them in first into that sort of front end triage, symptom checking, and eventually diagnostic, and eventually semi-treatment. You've seen a company yesterday called Wobot, which is an online bot dealing with depression and whatever. Got breakthrough designation. Great name. Raised $90 million. I must confess, for full disclosure, of the $90 million, I contributed well under 0.01%, but I put a couple of quid in there, as part of a little syndicate I'm in, because I thought it was an interesting idea. They've got a breakthrough designation for postpartum depression, where they've run it, and it's been very effective. So, the question is, can you scale up with machines? Can you scale up with the existing infrastructure of doctors? Can you put wrap stuff around where you give everyone, concierge style, more than one medical? I'm talking more like, Parsley Health or Forward Health, one of those primary care things. Because again, we're talking, though, the rough cost of that on the open market is about $1,500 a year, which is not a significant share of the average cost of an individual, the average amount we spend per person. It's not that significant a share of the amount we spend per person on healthcare in the country. However, of course, we don't spend it equally. We spend, most of that money gets spent on a few people, right? So, Casey, this year I suspect you've been rather expensive, and I don't think I've been.
Yeah.
So that's the issue. How we reconcile that, I don't know. We'd have to figure through. But I don't think it would be impossible to do what I said, Michael. With the only, going back to my political science degree, the only issue being that Stigler's theory of capture, right? The regulators are captured by the people who do what they do. And we've talked about the RUC enough on this show, and I don't mean the Royal Ulster Constabulary. I mean the committee that's dominated by specialists. That's why specialists get paid more than primary care doctors. So that's the problem, right? It's the politics of it. I think you could do it, and now with the technology, you've got a better chance of doing it, but doing it without, doing it against the politics is going to be very tough and take a very long time.
Yeah, I mean, well, just to sort of pile on that a little bit. I mean, the basic problem, though, you still come back to, is that there isn't enough capitation payment in primary care to sustain practice. I learned this from Bob Margolis 30 years ago. So unless you're taking risk, right, or you're getting a subscription on top, your fee doesn't cover it. I mean, we're building a medical group at MLK. I don't want to get into the finances, but let me tell you something. You're subsidizing doctors, and every one of these large health systems is subsidizing physicians to the tune of 100 to 200 to 300 grand per doctor per year. And the reason they're doing it is they're getting, I challenged my buddy who was on the board of the Palo Alto Clinic, saying, why are you giving me all this free stuff? I'm a PPO patient at the time. Why are you returning my phone calls? He said, because we're trolling for your invasive cardiology. They're going to get the expensive stuff, which is payoff. So that's why big clinics like Palo Alto Clinic and other big systems are subsidizing primary care. I would argue that to some extent, the startups are being subsidized by the venture capitalists. That the actual payment rates.
Oh, I mean, more so. This is very similar to Uber, right? Uber now charges you the sort of real cost because they have to start thinking about making money. But 5 years ago, you could go across town for a quarter of the price of a taxi fare, and it was better. But also, it was like a handout from the VC funds,
right.
Similar to I think there's something in that. All right, you guys
only burn money for so long before you have to find some other way of doing it.
Right.
Well, my sense, I am doing some calculations on a spreadsheet in the background here just to see if I haven't done this for a little while. But and I'm probably will screw up the math. But my analysis is that it will cost to give everybody a primary care doc, which would require one primary care doc for 500 people, which I think requires 600,000 if my math is correct. Is that right? Would cost about 2.4 trillion, which is not everything which would basically say that's 2/3 ish of what we spend on on care. Now, you would have to believe that doing that would improve everyone's health so much and make everything so great that you could both, make all those doctors primary care docs, and you would start saving a lot of non-hospital admissions. And I mean, you have to believe you have to believe the claims that, oh, we save 30, 35%. I've heard 50% downstream costs by getting everyone great primary care. I mean, if you believe that, you believe it. If it doesn't work, if you don't believe that, then you're giving everyone great primary care and you've added, 2 trillion to the cost of healthcare in the country, which we're probably going to do anyway. But to me, that
I think the answer would be
fair,
somewhere in between. But the health status of poor people would go up.
Yeah, and the folks that end up costing, to use it, this was, $1 Million Murray, Malcolm Gladwell's $1 Million Murray, which, God, that was in the New Yorker in 2006 and maybe 2005. But, that sort of end of life, or, people who reach an extremist point and then have to be scooped up in an ambulance and but if you could avoid all of that, think of all the money you could save. But, but they'd rather troll for your invasive cardiology procedures later. And go after the folks that they know have the money or the coverage to, give them the money that they want for those cardiology procedures. And so we just keep going, doing the same thing. We've always done it this way. And it's working out so well for some people.
No, look, I'm with you. I just did the math again, right? So it's if you pay $1,500 a month, which is $1,500 a year, which is roughly the cost of one of these concierge docs, you'd need 660,000 doctors, and you could give every doctor 500 patients, and that would be your primary care nut. If you gave them more patients than that, you could do it with fewer doctors. And if you gave them less money than that, you could do it with less money. It's an equation. I don't think that at scale anybody has shown that those savings, from spending more primary. Rishika Fandanopoulos at IORA says all the time, we spend double the amount on primary care and we spend less on specialty care. But I think I've said on this show, I did some analysis of the Humana data from I think it was 2 years ago, and it didn't show that the people who had big capitation payments and spent more on primary care actually saved a hell of a lot more than the rest of the fee-for-service people out there in Medicare Advantage. But that's the only rational way of getting to the sort of the change in the structure of doctors. I forget how we got to this point. We were talking about whether whether there was an oversupply there was a surplus of doctors from the AMA back in the 80s. The Michael was commenting on. All right. Okay. Okay. We should shut up about my redistribution of doctors, income, patients, and primary care fantasy, because it's clearly just that. And we should quickly. We're getting close to the end here, so we should quickly think about what we're saying next. But I would like just for a second to focus. I know we've been looking at it, just to focus on how bad this next round of the Delta and Lambda variant of the COVID is going to be, just for a couple of minutes, because I'm sure you've seen that death chart from the UK, which is, even though the infection rates have spiked up because of the viruses, the death rates and hospitalization rates are way down from the last time we had a big spike. Right. But I know in some parts of the US, we have Missouri and elsewhere, we're having massive spikes because not enough people there got vaccinated. So essentially it's disease of the unvaccinated. What's our sense? Does anyone have a sense about, is this just going to flare out and we're going to be okay? Or is this going to impact us enough that we might go into some wider issues come, November, December?
Well, let me start. I just say that I think it goes back to our Fox and Friends thing at the beginning, right? If there's a meaningful improvement and turnaround in the vaccination rate, then I think we can ameliorate it. I mean, I wrote the numbers down before we came on. We are at 49% fully vaccinated. The Brits are at 54. The Canadians are at 52. The French are at 42. And so we've been surpassed now by a couple of countries in terms of full vaccination. The French numbers, even though they've got Delta and some other thing, their death rates are not, they're up. The case rates are up, but the death rates are not up. But in my native Scotland, 3 of the largest hospitals in the Highlands have gone on code black, meaning they're not accepting electives again. So the cases are leading to hospitalization. There's no question. And I think it's going to be a horror show in September here in the US and the unvaccinated states, unless Fox News and the boys and the Republicans really try and turn out the residual population are resistant.
So in Scotland, are the people, the reason they're going on code black because of breakthrough infections or because of a lack of vaccinations?
No, they're going on code black because they are fearful that their hospitals are going to be overwhelmed with COVID patients.
But will it be unvaccinated or a breakthrough, do you think?
Oh, no, it's mostly unvaccinated. It's young people, right? And people giving it to people. There are some breakthrough infections, but we know it's like 95%.
So it's a problem even without the public. I mean, you know, one of the issues in terms of the politics here is Trump got vaccinated, but did not try to get others vaccinated, but he survived, right? And we haven't run any, I've said this before on this program, we haven't run any ads of him saying, I got vaccinated. And there was a news article saying he's now going along with his base. Okay, if you don't want to get vaccinated, I'll say it. So if you all of a sudden saw Fox News people ending up in the hospital, if all of a sudden you saw a prominent Republican congressman dying, right? That would do it. But the problem in terms of the politics and the perception of the people is that the people who are telling them don't do it, who are prominent or defending the right not to do it, are themselves vaccinated. And so they can't see the consequences, as it were, among, you know, the people who are telling them not to. And so it becomes difficult, right? That the upper middle class and the you know, the talking heads and all the rest of that, they got themselves vaccinated. And so if we have an outbreak in rural Arkansas, you know, will that change public opinion? Which we do, right? How much does that change opinion? I mean, you saw that they went and they talked to people in parts of Oregon that were overrun by terrible fires, and it didn't change their opinion on you know, climate change, right? And so if you have people who, when reality affects them, refuse to accept that as reality, that's terrifying. And if some of the people who could help them change their minds won't step in to do it, then I'm not sure where that leaves us.
They're earning a living by lying, basically. You know,
correct.
I mean, this is it. But welcome to American hypocrisy. You know, we're good at it. I think we're probably the best ever minted. You know, that Americans are some of the most hypocritical people you could ever find. But you know, as a nation, and it just you know, we lie to ourselves. We've been lying to ourselves for, you know, however many years it's been since 1776, when somebody wrote that all men are created equal. Well, it didn't include women, and there were a whole bunch of other people that were even men, but that weren't included anyway. But it just, you know, I mean, it gets to a point where, you know, we just have to admit that we're not the beacon of wonderfulness that we like to sell to everybody else. Is, you know, that we are actually more screwed up than, you know, places we refer to as third world nations. And it's only when we admit that we could start driving some change. We're not there yet. Stay tuned for updates. But meanwhile, this winter is going to be hellish. Between flu and COVID, it's going to be, you know, it's going to be welcome to the, you know, 13th century and the Black Death.
All right. Well, on that optimistic note from Casey, we're gonna wrap and talk. We got through a lot today. Part of my fantasies about primary care, a little bit of vaccine, something about equity, and some other stuff. And now we're going to go quickly around the horn and say what are we expecting to see in the next couple of weeks. So start with you, Ian.
Oh, I just is there an uptick, a rebound in vaccination rates as a result of this? I mean, I hope so. I think that will be our salvation.
Michael.
We're going to look a lot at COVID, but we're also going to be paying equal attention to what is Congress going to pass, right? With healthcare, with infrastructure, with things addressing, because a lot of the healthcare is in fact related to people's access to childcare and a lot of other things. So I think as the congressional session winds down, that's going to be part of the focus, along with the clock ticking on vaccinations in the Delta variant.
Casey, other than the Black Death coming back and bringing out your dead and Monty Python sketches, what do you see in the next few weeks?
Well, I think that I'm with Ian, and I'm hoping that this will at least spur some kind of acceleration in vaccination rates, at least, short term. I can only hope. I basically crawled across broken glass to get my 2 vaccines before I started cancer treatment. So, you know what side I'm on there. But the other thing is, trying to track the number of infections and also a better understanding of what breakthrough infections look like, so that those of us who are vaccinated but who could still be at risk for some of this more virulent stuff, with Delta and Lambda, to know what to look out for.
All right, well, my next couple of weeks, number one is there is no THCB Gang next week because I'm going on vacation just for a week to Lake Tahoe. And pretty soon after that, I'm going to the other epicenter of COVID outbreak in America, Las Vegas, for the HIMSS conference, if it actually happens and they don't decide to cancel again. I don't think HIMSS can afford to do that again. So I will report back as to whether how breaking through those breakthrough infections are going to be over the next couple of weeks.
Wear your mask, buddy.
All right. Well, thanks for that. Okay, so want to now show the PowerPoint, as well as I screwed it up on the way in, as who we had on this week. Come on. There we go. I want to thank all of you for listening. My guests this week were Ian Morrison, all the way from the crazy wilds of Menlo Park, California. Michael Millenson from the solid Midwestern town of Chicago, Illinois. And Casey Quinlan, all the way from the heart of the Confederacy, Richmond, Virginia, which he does not represent. I would like to point out that on that. This was episode 60 of THCB Gang. Thank you for watching on the video or listening to it on the podcast. This is Matthew Holt saying we'll be back in 2 weeks' time. So not Thursday. I'm not making my guess. Not Thursday, July the 29th, but whatever that first Thursday in August is. I'll figure it out next week. Looking forward to seeing and talking to all of you then. Thanks for watching and listening.